My name is Keegan Wong. I'm a practicing pharmacist and a WA branch president of the Pharmaceutical Society of Australia.
My name is Mei Fung, the WA State Manager of the Pharmaceutical Society of Australia.
One of the points you make is that seeking access to medical cannabis can be difficult. Could you explain what your thoughts are on this and how the problem might be addressed?
As a patient who is in chronic pain and who's suffering from daily, daily struggles of managing their pain, having to undergo a significant amount of laborious paperwork is a significant impact. For practitioners out there, it's quite a laborious task for them to do. So that consumes their time and also for other patients as well. So we have to understand that also impacts other patients, not just this particular patient.
Could you describe the difference between an authorized prescriber and a non-authorized prescriber GP prescribing?
When you prescribe a medicine that is not a proprietary medicine that is listed on the therapeutic goods site, the prescriber it's a requirement that the prescriber actually applies to the therapeutic goods and says, I would like to prescribe this medicine for this patient that is de-identified for this indication. It then goes to the TGA, who then authorise that and provide a reference number back. Once a prescriber has shown that they have prescribed this product for a period of time, correct me if I'm wrong, but I think it is 6 months or so, they're able to apply to become an authorised prescriber, which means that they don't have to fill out the SAS form each and every time, but the TGA will authorise them to prescribe a certain list of products within maybe a certain brand or, so for example, it might be Little Green Pharma and they can prescribe anything within the Little Green Pharma range. But then if they want to prescribe something else, they'd still need to go through the SAS form. And then the prescriber would then need to report to the TGA all the patients that they have prescribed which product for and how much, and they'll need to report that, I think, every 6 months.
One of the things you said in your opening statement is really that cannabis should be used as a last resort. I think you said when all other medicines had failed. Why would you use it as a last resort? Why wouldn't it be something that a medical practitioner would consider early on?
Only then, if those medications have failed, then we advance to the next level. And basically, considering in the place of medicinal cannabis, it's a fairly new, whilst the cannabis has been around for many, many years, the use of medicinal cannabis is still fairly new and fairly novel in our current community. So we believe that conventional therapy should outlay for pain medication relief.
It's not always the best for everyone. It works well for some people, but I think having this other option, in my personal view, is probably good to have there.
You mentioned initially that CBD is the one thing. There's plenty more than CBD in the cannabinoids. But you added THC as the second component, the second commonly tested component. And you said that it's not suitable for those with mental health conditions.
May not be.
May not be. Now, THC can certainly cause anxiety and paranoia, dose dependent, but it can also treat anxiety. We also have a 30 milligram upper limit before we need specialist support to get that for 60 milligrams. What is your opinion about those upper limits?
I think the upper limit is going to vary from person to person because with the medicinal cannabis products, because they're lipophilic and don't follow linear pharmacokinetics, which means that when someone takes it, they'll take it and they might find it works, and then all of a sudden, and the GP or the prescriber might be actually gradually increasing the medicine. And they'll find at a certain point it may not work, and if they reach the upper limit, we say, okay, pause for 6 weeks, and because what happens is that the medicine starts to store in the fat, and so that means that the upper limit can vary from person to person. I believe also with the endocannabinoid system within our body is that our body actually produces this naturally, and that can also vary from person to person, and because it is produced by a wide range of organs in the body.
In your submission, you actually talked about how the prescriptions of these pharmaceutical products usually falls to GPs, and that it places an additional strain on the healthcare system. Taking everything else you've just said, what would you suggest an alternative then would be?
Yeah, I still believe that general practitioners with a specialty should have should be allowed only be allowed to prescribe this particular medication. However, a more streamlined approach should be adopted. So be it on a streamlined authority by an approved authorized prescriber, for example. these are just personal suggestions, you know. And if a patient was to walk through those doors in my pharmacy who's in chronic pain and limping through, I should be able to trial a cannabidiol product for them before, and monitoring them closely before, and referring them to their local GP. But at this point in time, we have not got, whilst it's legalized for an S3 on a low-dose cannabidiol product, we have not yet seen a product come to market in Australia yet.
I believe it's quite an expensive process to meet the rigorous TGA guidelines in order to become a proprietary product. But if the government was able to support that, that would definitely enable access. And I think if I go back to, you know, it is very onerous, you know, I think if I had a chat to the health department to say, hey, like each time, because it's an SAS medicine, the GP needs to do an informed consent form because it's not a proprietary product. Can this be merged with S8 treatment form? Because that will be one less form people sign once.
Yep.
And I believe it is a possibility, but I think for people to know how they can do it, I guess we would also ask for further education to be available that was government subsidised to pharmacists as well as prescribers or people that are potentially thinking about prescribing medicinal cannabis, because I think just having further education out there that is not necessarily from a pharma company, so it's unbiased, would actually have more people feeling like that they can listen to the advice.
We've spoken about risks of cannabis and cannabinoid preparations. Could you give me a comparison, please, of the risk of death with opioids and cannabis?
I actually haven't got any information on that at this point. Bailey, have you got?
I don't have
evidence?
that comparison with me right now. We can get back to you on that.
Would you please? From the addictive potential, do you have any idea about the relative addiction potential between alprazolam and cannabis?
I don't have anything specifically, but anecdotally, like my information is that alprazolam as a benzodiazepine is highly addictive, and benzodiazepines dependence can develop within 2 weeks or less. Compared to medicinal cannabis, as within the product itself, as opposed to just plant cannabis, medicinal cannabis is not supposed to be addictive.
Do you find much difficulty with patients finding doctors prepared to prescribe cannabis?
Yes.
How frequent is that?
Well, as frequent as those who are suffering from chronic pain. So essentially, a lot of people, a lot of communities turn to the pharmacist to ask which GPs do prescribe medicinal cannabis. I don't think there's enough information and resource out there for the community to give them that direction as of now.